liver transplant surgeon. Before I introduce him, I again pay my gratitude to Sushil sir. I pay my gratitude to Physicians Forum of India. I have been almost nurtured by all of you, and today I meet a lot of people and they tell me that I'm a big gastroenterologist. I don't believe that. I still think that whatever blessings I have nurtured from you guys is what makes me moderate a session for a stalwart like him. So it's not about me today, but it's about Physicians Forum of India and it's about Dr. Shaleen Agarwal. So talking about Dr. Shaleen, he's a senior liver transplant surgeon and a gastrointestinal surgeon who is specializing in the field of LDLT and hepatomegaly and pancreatic surgery. He has more than 20 years of experience in this specialty and has been practicing in Delhi NCR for the last 15 years. He is known for expertise in LDLT, hepatopancreatic biliary surgeries, liver transplants, hepatopancreatic biliary cancers, and a lot of other hepatopancreatic biliary surgeries. He is MCH GI surgery from the renowned Sanjay Gandhi Postgraduate Medical Institute in Lucknow, and is MS General Surgery from the renowned Institute of Medical Sciences in BHU Varanasi, and he was MPH from the same institute. So welcome you, sir. I met you for the first time. I hope one of my cirrhosis patients is soon transplanted by you, and it will be a pleasure. And we welcome you to Physicians Forum of India, sir.
Before we give it to Dr. Shaleen, there is a video on Amrita Hospital, and I request Mr. Ram to please play that video for all of you, right? And then we give it to Dr. Shaleen.
So before we get the doctors up to talk on topics that are definitely going to be of interest to you, I just want to take a couple of minutes and give you a little bit of the philosophy behind Amrita Hospital as to why we exist. I mentioned the vision a little bit before, but the reason we exist is because of our visionary leader, our founder, Sri Mata Amritanandamayi Devi, Amma. And the reason she started this hospital, and is the first one in Kochi, Kerala, 26 years ago, was because she saw in her personal life how difficult it was for people to get good quality healthcare at affordable cost. So that was the reason why she started that hospital there. And it's been doing some groundbreaking work for the past 26 years. Every single first thing in the country or in Asia, you would find Amrita Hospital listed over there. So she wanted to duplicate that in North India, and that is why she started Amrita Hospital in Faridabad 2 years ago. So we've been in operation for the past about 2.5 years. So I just wanted to show you a very quick video of who Amma is and what she does, how she has dedicated her entire life to uplift humanity. So here's a very short video of who Amma is. So that's who Amma is.
लाइट जला दिया.
Before I get the Dr. Shaleen up, I don't know how many of you have had the opportunity to visit the hospital in Faridabad. So here's a very quick intro to Amrita Hospital. Just a very, very short video. So the largest private hospital in India and actually is in South Asia. That's what Amrita Hospital is. And as Dr. Chauhan mentioned earlier, what sets us apart is why we are able to do what we are able to do is because we are not a true corporate hospital. Nothing wrong with corporate hospitals. But how Amrita is set up is that we are a private hospital, but we are a non-profit organization. And that's what allows us to give the world-class healthcare at affordable cost. With that, let me turn it over to Dr. Shaleen to talk to you. Thank you very much.
So at the outset, I would like to thank the entire physicians forum of India and all the esteemed doctors that are present here. Dr. Chauhan, thanks for a humble introduction, and I'm very humbled by what he said about all of us. And before I start my topic, I would like to speak, although Mr. Ram has introduced these nice videos, but I have been with Amrita only for the last 4 months. But it's been my experience that I've regained at the age of 53 the same enthusiasm and same idealism which I used to have when I passed out my UCS and came back to India from the United States after doing my liver transplant fellowship. I was in the corporate world and I worked in the government also, but I must admit I'm speaking from my heart that I was in GP Hospital as an assistant professor in GI surgery and then subsequently at the Institute of Liver Sciences in South Delhi only for a year. But I realized that there was a lot of cynicism that grew in me one, I wasn't making much of money, even after studying for almost 16, 17 years, getting very paltry pay. And at the same time, I couldn't realize my dream of doing some good work. So nothing against, because I'm really indebted to the medical education system in India, because we almost got educated for free, and I'll always be indebted to all my life, and I want to give back to the society. But then I moved to the corporate world for the simple two reasons: I could make more money, and at the same time I could do some cutting edge work for which I had trained in the United States, that is liver transplant. So I got that satisfaction there, but then the cynicism inside me kept on growing, because I always felt I was like a fish out of water, because I thought I was catering to a very limited percentage of the population, not even 1% of the population who could afford that kind of care. So affordability in healthcare has been always a big issue, not in country like middle income or a lower income country like India, but even in the United States. The healthcare cost is a very major issue even there, and their presidents keep on talking about it. So that dissatisfaction was always there, and I always wanted to be associated with an academic institution. So I kind of satisfied myself, reconciled that well, you cannot get the best of both worlds, you have to just stick to whatever you're doing. But then Amrita came in. And I studied their ethos, their philosophy. I've been in touch with the transplant team at Amrita Kochi for many, many years. I always liked their working pattern. And then I realized that whatever I had always wished for, that I could treat a major proportion or a good proportion of my countrymen who are poor, who cannot afford, but at the same time I can have a decent income for myself also, for a decent living for my family and for my future. At the same time I can contribute to research, teach students so that I can give back to what I have taken from my country. So all these things I am realizing, and it's been only 4 months that everything is getting fulfilled at home. So, and it is all because of our spiritual leader, Amma. And again, just a word of, I've met her only once, but and I've not been into any kind of cult or following any gurus or anything. We are all rational people, as we call ourselves, but there's a difference. There are a lot of gurus, cults, ammas in our country. It's been a tradition, and a lot of spiritual gurus all around. But the only thing I found different was that she's a lady who has not even had any education. She comes from a very humble background. She was a poor fisherman's daughter, but she had this spiritual awakening at a very early age, and just from 7 huts, it's grown into a big institution, all from contributions from people like us, poorer than us. And the only difference that makes her different, in my opinion, from other spiritual gurus and teachers, no offense meant to anybody, is that majority of her followers are highly educated professionals. People who won't take anything for granted, no charlatans or anything can influence them, because they test everything on the stone of logic. And her followers, majority of them are highly trained, highly educated professionals. So there is something about her. And her entire motto is that not only, so many people talk about opening schools, even Kejriwal and everybody talks about it, we open schools, colleges, hospitals. That's I think, worn out kind of statement. So everybody wants to do good, so I want to open a school, I want to open a hospital. But what is different here is that you have to run them professionally, and not only that, you have to promote research, you have to be at the cutting edge. So if you ever happen to visit Amrita, you have to see the research background or the amount of research that's going on at Amrita Kochi, and that we intend to replicate here itself. So that is the difference, that we not only treat the poor, we also treat the rich people. After all, there's nothing wrong with earning money, but it's wrong with how you earn it. That determines whether you have lived your life as a doctor properly, or it's just like any other businessman. So the only difference here is that we are not only treating the poor, we are also treating the rich, but at the same time we are giving a quality care. And I can assure you, I have worked in multiple corporate hospitals before also, that the expertise, not only the human expertise in the terms of experts, but also the equipment, the infrastructure that has been created here is, I would say, one of the finest in the country. So with that background, I would like to start talk about a little bit about my specialty. And since I'm a GI surgeon with training in liver transplantation and hepatobiliary surgery, so the topic I've chosen is to give you just a bird's eye view about the common liver diseases and liver transplantation. So as we all know, just a brief introduction, liver is a unique organ. It is the factory and the powerhouse of the body. Myriads of metabolic functions. It's been calculated that the liver performs more than 500 physiological functions, right from metabolism of whatever the food is ingested through the gut. At the same time, a lot of immunological functions, and newer ones are being discovered with every passing day. Liver is a huge immunological organ. It is not only a digestive organ, it's a huge immunological organ, and it's the sentinel of the GI tract. The functional reserve, that is the unique thing about liver. You can safely resect up to 70% of the liver and the remaining liver grows back. And that forms the basis of a living donor liver transplant, this huge regenerative capacity of the liver. So quickly going through the broad categories of liver diseases. One, we have the chronic liver disease or cirrhosis that we all know. Then you have an acute liver injury or acute liver failure, which is a kind of real medical emergency. That is the only liver emergency for a transplant surgeon, that is acute liver failure, because it can be fatal within 24 to 48 hours. A totally healthy person who you are talking to, sitting nicely, moving around like any other healthy person, within 24 hours goes into a coma, and just if not intervened, will die, will go into he will go and have develop brain death within 24 to 36 hours. So this is a real emergency as far as transplant surgeons and hepatologists are concerned. Then you have a category of liver neoplasms, the most common being the hepatocellular cancer, followed by cholangiocarcinomas, and then as you all know, that liver is the site of metastasis from almost all GI cancers. Another subset is the metabolic liver disease, usually seen in children, the most common ones being the Wilson's disease, then you have maple syrup urine disease and others. And then a rather rare group of vascular disorders, the most common being the Budd-Chiari syndrome. So what is cirrhosis? So it's more of a pathological diagnosis, and it represents the end result of a wide variety of chronic liver diseases, and histologically characterized by three features, namely fibrosis, the loss of normal architecture of the liver, and presence of regenerating nodules. So many times we would say, oh, you have developed cirrhosis, आपका liver सिकुड़ गया, छोटा हो गया. But actually, in a cirrhotic liver, there is no dearth of hepatocytes. Actually, cirrhotic liver has more hepatocytes than a normal liver. But the function of the liver is dependent on the anatomy of the liver. We all remember from our pathology days the structure of the liver nodule, and that forms the basis of a normal function. And since there is a distortion of the normal architecture, the liver suffers the portal flow is obstructed, you develop portal hypertension and the subsequent complications. So the complications of cirrhosis is not due to the dearth of hepatocytes, it's just because of the loss of the normal architecture. So the common etiologies of chronic liver disease from our old days, we know it's chronic viral hepatitis B and C, but in the current scenario, since this is an update, Hep B and C are actually coming down in their prevalence, simply because of the introduction of very good vaccination schedule as well as antivirals, especially for hepatitis C. So the prevalence of B and C both is coming down, though we still have a large group of middle-aged and elderly population when the vaccination was not so common, the antivirals had not been introduced, who are coming to us with cirrhosis. But this, as of now, is not the most common cause of chronic liver disease. Rather, it's the ethanolic liver disease. I would say not the epidemic, but the pandemic of ethanol abuse. It's not only limited to, you will be surprised, not limited to metropolitan areas or cities. The rural areas are no different. Alcohol abuse is rampant in our country. And I think we sometimes take pride that we are a very spiritual country, but I feel that it's no different from any other Western country or a material country. The alcohol abuse in our society has become kind of a norm these days, and it's become kind of accepted, which is a very unfortunate development. Close on the heels of ethanolic liver disease, we have what we call the MASLD, or the metabolic dysfunction associated steatotic liver disease, or more commonly as we remember as NASH. So this terminology has changed from NASH to MASH now, and it's a combination of various factors such as obesity, dyslipidemia, hypertension, whatever the components of metabolic syndrome are. Just like they affect the liver and the heart and the brain, so do they affect the liver at the same time, and end result is again cirrhosis. And then you have rather uncommon disorders as a cause of cirrhosis, such as cholestatic liver disease, metabolic, vascular, and disease burden. Just to give you a brief overview, cirrhosis is the 11th most common cause of mortality, and in India we have, and yes, mind you, liver cancer is very common in patients with cirrhosis. It is said that more than 90% of liver cancers occur on a background of cirrhosis. In healthy livers are somehow protected from cirrhosis, from liver cancer, So once you have cirrhosis, you become very prone to develop liver cancer also, and there comes the role of close screening and surveillance of these patients. And nearly 2 million annual deaths have been reported as per the WHO registry, of which around 20% are coming from India alone. So from that you can gauge the disease burden, and this is just a pictorial representation of what I just said, that we are in the real red as far as liver disease and liver cancer morbidity and mortality is concerned. And then if you look at the global picture, the red means the increasing prevalence, and we are somewhere in between. So the only blue areas are African areas where, because of the hepatitis B vaccination and good antivirals, the prevalence of cirrhosis is going down. Otherwise, in the rest of the world, it's increasing at a varying rate. What is the natural history of cirrhosis? So once you have chronic liver disease, you progress to compensated cirrhosis, that you are histologically or radiologically you have a liver which looks cirrhotic, but you are perfectly healthy. After a few years, you develop decompensated cirrhosis. By decompensation, we mean the development of symptoms such as jaundice, encephalopathy, ascites, variceal hemorrhage, and some others. These are the 4 most common. And if it's not treated, then early death. So the complications of cirrhosis can broadly be divided into 2 categories. One, which are the result of portal hypertension, such as variceal bleed and development of ascites, pedal edema, hydrothorax, subsequently leading to bacterial peritonitis and hepatorenal syndrome, and one due to liver insufficiency per se, the hallmarks being jaundice and encephalopathy. And the patients present in various permutations and combinations of these 4 most common symptoms. In addition, these days, especially the alcoholics may present with cirrhotic cardiomyopathy also. The common symptoms being that they present just like any other congestive heart failure, and actually it's a liver disease which is leading to the cardiac dysfunction. So obviously decompensation reduces survival, and this graph represents that, the difference in the survival, median survival of a cirrhotic patient as well as decompensated cirrhosis. So once you have decompensated cirrhosis, in general it's said that your survival, even if the best Medicare currently available, is less than 2 years. So what are the therapeutic options? So first you start with the medical management, which we all know. But unfortunately, none of these medications can actually reverse the underlying damage or establish cirrhosis. These are just symptomatic medications, symptomatic treatment in terms of beta blockers, diuretics for ascites, antibiotics for the frequent infections that these patients develop. Albumin, yes, it helps in controlling ascites and renal dysfunction to some extent, but again that is very temporary. And the median survival in the best of management is less than 2 years, as I just said. Then once you have more advanced disease, you have minimally invasive approaches such as band-like endoscopic variceal ligation for the variceal hemorrhages. BRTO is another similar kind of treatment for that. That's the balloon retrograde obliteration of varices. Large volume paracentesis once the ascites doesn't get controlled with diuretics, and then TIPS is another option for controlling ascites, but they have their own side effects. But mind you, none of these treatments is curative. The only curative treatment once a patient develops decompensated cirrhosis. So there is a difference between compensated and decompensated cirrhosis. I would never recommend a liver transplant for compensated cirrhosis except in the scenario of liver cancer. But once you develop decompensation, which can variably develop from between a period of 2 to 3 years to even up to 10 years, patients may remain compensated for 8 to 10 years, but ultimately all will decompensate if they don't die due to other causes. And once you have decompensated cirrhosis, only curative treatment remains is liver transplant. So why liver transplant in cirrhosis? And as you can see from this slide, that as the complications progress, so the survival goes down exponentially, and once you have renal dysfunction, the 1 year survival is to the tune of around 10 to 15%. On the other hand, if you have a successful liver transplant, the chances of being more than 95%, your survival at 1 year would be 85 to 90%. And even at 5 years, it would be 75%. At 10 years, unlike kidney, livers, we don't know what is the life of a transplanted liver. A transplanted kidney usually would last from 8 to 15 years, depending on whether it came from a deceased donor or living donor. Living donor kidneys are going to live a longer life, but ultimately, the kidneys are likely to fail. Majority of the kidneys, the median survival is around 8 to 10 years. On the other hand, we don't know what is the median life of a transplanted liver. Therefore, even at 10 years, 60 to 70% would still be doing well after a liver transplant, unlike a kidney transplant. And this is how the liver patients fare after a liver transplant. So how do we decide? This is the time tested that we have all read in our MBBS days, the child SPEW scoring system, which is based on 5 criteria. That is the serum bilirubin, albumin, INR, ascites, encephalopathy, and the total score being 15. So what is the criteria for deciding? So we have to be objective when you offer a liver transplant to a patient. So once a patient has been in child C, that is a score of 9 or above, these patients merit a liver transplant. Just because once you enter a child C grade, your mortality at 1 year is to the tune of around 40%, maybe even more. And more objective than the child scoring system is the MELD scoring system, and what we currently use is the MELD sodium scoring system, which is based on 4 parameters, that is the serum bilirubin, INR, creatinine, and the serum sodium. So since encephalopathy can be interpreted differently by different physicians, so this system removes all the subjectivity from the scoring, and it's based on completely very basic lab parameters. And it's been clearly shown that as the MELD score rises, so does the mortality. And to the extent that once the MELD score reaches 40, the chances of your dying within the next 3 months is nearly 90%. So any MELD score, it is said that above 15 should be an indication for liver transplant. And this slide again shows that with the increasing MELD score, the survival benefit of liver transplant increases just because the higher the MELD score, the higher is the mortality in the short term. And so is the greater is the benefit of a liver transplant. So if I want to summarize, what are the accepted indications for a liver transplant? Any child score of 9 or above, MELD score of above 14, although some recent studies have shown that the benefit starts right after a MELD score of 12. Then hepatocellular cancer is a unique indication for liver transplant, though every cancer cannot be transplanted. There are certain criteria called the Milan or the UCSF criteria, which I would allude to in the subsequent slide. And then the only indication for an emergency liver transplant is acute liver failure. So again we have the criteria, perhaps many of you would be knowing the King's College criteria, the Clichy criteria, but these are not being used currently. The King's is still followed. We have our own Indian criteria now available for deciding on liver transplant in patients with acute liver failure. So what are the exceptions that when even with a lower MELD or a lower child score you will do transplant of a transplant is refractory ascites. Patients requiring frequent LVPs every week to 10 days, these patients should be offered a liver transplant. Recurrent SVPs, that is spontaneous bacterial peritonitis, these patients have a very high mortality within the next 2 to 3 months, so they should be quickly transplanted despite low MELD scores. Unresponsive variceal bleeding is a very rare indication because our gastroenterology colleagues have become very expert at controlling bleeds by various methods, EVL, ERTU, etc. Intractable pruritus is a rare indication for liver transplant despite a normal MELD score, and then recurrent hepatic encephalopathy. This was what I was talking about, liver transplant for hepatocellular cancer. So these are basically the number and size criteria to determine the tumor burden. It's been shown that if the tumor burden is mild to moderate, that is if you have up to 3 tumors none greater than 3 cm and a total tumor burden of less than 9 cm, then these transplants should be ideally offered liver transplant because they have the best outcomes when compared to other modalities of treating liver cancer, whether it's surgery in terms of liver resection or currently available immunotherapy, radioembolization, chemoembolization. There are several modalities available, but if the patient is falling within this criteria, liver transplant beyond doubt will give you the best survival in terms of overall survival as well as disease-free survival. Word about liver transplant in acute liver failure. So as I just said, it's the only indication for an emergency liver transplant. However, with improved ICU care and experience, more than 60 to 70% of our patients can be salvaged without a transplant, and we always attempt aggressive medical management for 48 to 72 hours before we tell the family that okay, now it's not working and you need a liver transplant. The most common cases that we are seeing, unlike in the West where paracetamol overdose poisoning is the most common cause of acute liver failure, in our country these days we are seeing it's the viral infections, most commonly being the hepatitis A. Every week we are getting 1 or 2 patients of acute liver failure because of hepatitis A, which is, as we all know, is a food and waterborne infection. So this is the commonest cause of acute liver failure in our country. Then once the dengue season will come, we will have multi-organ involvement, including acute liver failure second to dengue. And we have realized that majority of these patients will recover without a transplant with good ICU care. But then you have to be very vigilant that if the patient is developing signs of intracranial hypertension, they are at a huge risk of herniation and brain death. And then if you consider liver transplant at that, these patients have to be ventilated. And there are many other modalities for good ICU care. where you can increase your rate of salvage without transplant. But then you should be ready for transplant at any hour of the day. What are the absolute contraindications for liver transplant? One is irreversible brain damage, as we sometimes unfortunately see in patients of acute liver failure, and usually these patients are young people or children or teenagers in the prime of their life. And I have seen patients just becoming brain dead within hours while we were preparing for a liver transplant. So that is a very unfortunate happening. Patients with multiple system failure, not correctable by liver transplantation. So now what is happening, more and more patients are being managed medically and they are moving from one hospital to other. Decompensated cirrhosis, okay, some doctor will say, I'll drain your ascites, then they will move to the other doctor, okay, now I'll manage your encephalopathy with medications. They tend to improve, go back home, because it's very natural. Nobody wants a big surgery, especially when you have you want a living donor, your near and dear one is supposed to donate a part of the liver. So I would do the same. But what is happening, actually the patients are coming to us in multi-organ failure. Their kidneys are failed, they are in congestive heart failure, they are in deep encephalopathy, they have picked up multi-drug resistant infections not responding to the best of the antibiotics that you can think of. So a transplant in such patients is very often futile. Normally we offer transplant to a patient when we can assure a 1 year survival of around 80 to 90%, I would say 85 to 90. But then when you have patients like this, you won't have survival, 1 year survival of more than 50%. So it becomes a very big ethical dilemma for us, because the family is now pressurizing you that, okay, sir, the patient is dying, you have to do something and do a transplant. When we get emotionally carried away, do a transplant, we end up with a failure after transplant, and then you get the blame, okay sir, you did a transplant, you charged us so much amount of money, our donor has undergone a surgery and the end result is zero. So this has become a kind of ethical dilemma. The only thing I would request all my physician colleagues and wherever I go and give talks is a timely referral, which makes all the difference. You are doing good surgery, you are doing the same surgery in a sick patient as well as in a moderately sick patient, but the outcome is totally different. So it's not the surgeon's or the physician's fault, it's ultimately the patient's body has already given way. He's in multi-organ failure, so transplant is not going to create magic. So timely referral is the key for good outcomes in liver transplant. Extrahepatic malignancy, of course, it's an absolute contraindication. Uncontrolled infection, and that is what I just talked about. Majority of these patients are in multi-organ failure secondary to uncontrolled sepsis. Active alcohol or substance abuse, it's a contraindication because it's been shown through studies over the years that most of the patients who are actively abusing alcohol will go back to alcohol after their transplant. Whatever they will promise you or they can give you that I'll never touch alcohol, but majority of these patients, because they don't realize, they came in a very sick state, you did a transplant, so they don't know what is alcohol abuse. Once they undergo a successful liver transplant, they become so healthy that they cannot stay away from a drink. So it is said that you should, if the patient can stay well for the next 3 months, in the West it is said 6 months of abstinence period is mandatory before you offer transplant to an alcoholic patient. But sometimes these patients come in a very bad state, and now some exceptions are being made throughout the world because these are young patients whom you can salvage, but still the recidivism rate in these patients is to the tune of 30 to 40%. Of course, advanced cardiopulmonary disease, systemic disease is a contraindication, and then there family support is very important for a post-transplant care, or for that matter for any transplant care. So this is just to say that timing is of paramount importance. It's the key for a good outcome. It's not me or the physician or the surgeon. It's the timing of the surgery, timing of referral, which makes all the difference between life and death. Coming to some technical aspects, I won't bore you with that, but just give you just a brief overview. So types of liver transplant, basically from where the organ is coming. It could be a deceased donor liver transplant, what we call the DDLT, which is the most common form of liver transplant in the West, simply because organ donation rates in those countries, especially Spain, Europe, includes UK and then North America, both United States, Canada, the donation rates are very high. Just to give you an example, in our country, the per million donation rates they have increased, they have improved from 0.3 to 1% per million population. In Spain, it is 32. In USA, it is 26 donations per million population. So that is the difference, 26 to 30 times more than India. But things are not so bad. We have been for the last 20 years, and my senior colleague, Dr. Anandh, he is very proactive. He's a neurosurgeon, and those are the places from where organ donations come. He's been very proactive with that. So with the help of people philanthropic people like him and others, the organ donation rates are going up in our country. So I would request all of you using this platform that we should always be aware that any brain dead patient, we should broach the topic of organ donation to the family. So they would listen, mostly they will refuse, but yes, many would come forward to donate. And I realized previously I used to think it's only the educated who will donate the organs of their loved ones, but that's not true. I've seen very uneducated people coming from rural backgrounds, poor farmers who have donated the bodies of their loved ones once you convince them properly. Again, disease donor transplantation can be of two types. We all know about donation after brain death. Once the brain death committee of the hospital has declared brain death, after 2 APM tests, you can take away the organs as per the law. But then there is another kind of donation, that is donation after cardiac death, which is the death in common parlance once you have a flat line on the ECG. So it's not that any person coming dead to the ER, you can take the organs. There are certain criteria for that. So you can take the organs even when the heart stops in special circumstances. For example, a patient who's been chronically ill, admitted to the hospital, imminent death, family is willing to donate. So you shift these patients to the OR, withdraw the supports, and then wait for 20 minutes. When the heart stops, you can take the organ. Or a patient you cannot do the APM test. You cannot prove brain death because there are criteria for brain death. That is, the BP should be stable, the sodium should be at a particular level, and you cannot achieve these criteria. So these patients are also ideal donors where you can take organs once the heart stops. So under controlled conditions, donation after cardiac death has gone a long way in the West in increasing the donor. And in countries like India, where you don't have that many deceased organ donors, you have the backup option of living donor liver transplant. And not only India, the whole of Asia, living donor liver transplant has become the most common form of liver transplant, whether you call it fortunately or unfortunately. And then again in living donor liver transplant, you can cross the blood group barrier, and you can do transplants across the blood groups. It could be a liver transplant or a kidney transplant. Now we have techniques where the incompatible blood groups are no longer a contraindication for transplant. A can give to B, B can give to A, not a problem. And then you have weird exchange or swap at the end.
Shaleen sir,
I'll just
requesting you to wind up.
Yes, just a couple of things. Right? What are the pros and cons of DDLT? One, there is no donor risk. This is the biggest criticism of living donor liver transplant, that you are putting a healthy person to some risk, because every surgery is a risk. Deceased donor, on the other hand, it's organ coming from a brain dead person, but then you have paucity of donors, you don't have that many donors, and you cannot decide on the quality of the graft that you are getting. On the other hand, LDLT is an elective planned surgery. You can optimize your patient condition, choose a healthy donor with a healthy liver, and there is no waiting period. But then the most important criticism is donor safety concerns, and there have been donor mortalities in living donor liver transplant, but the rates are 0.01 to 0.02%, but then mortality in a healthy person is a mortality. And what is the basis of living donor liver transplant? It is just because of the segmental anatomy of the liver. The liver, which looks like a one organ, is actually 9 segments, and you can take out each segment individually surgically, but for all practical purposes, in adults we take either the right lobe or the left lobe of the liver for transplant. In small children, we can take the left lateral, that is segment 2 and 3, and even in infants we can take individual segments, segment 2 or 3 for transplantation. And just this is to show how liver transplant is growing in India. We have a very good future of liver transplant in India, and India has become a major hub of liver transplant for international patients. Also, a major chunk of international tourism is being supported by a liver transplant. So this is how a full liver looks like once it's out of the donor. And then this is how you divide the liver in a living donor. So this is just some pictures. I don't want to go into details of how, and this is how a living graft looks like. Taken half of the liver, this usually 60% of the right lobe, possibly 60% of the liver taken out from a donor. It's a more complex surgery, definitely takes longer compared to a deceased donor. But then it is the only life-saving procedure available when you don't have a deceased donor. And this is how it looks like once you have taken out the right lobe. And this is the cirrhotic liver, how it looks like once you have explanted. This is called an explant liver. And this is how the liver looks like once you have implanted. So, sorry for exceeding my time, but thank you very much for your patience.
Thank you so much, sir. We'll take the questions at the end of the second talk. I would give the mic to Sushil, sir, for introducing the next speaker.
Thank you, Dr. Shaleen, sir. Please come here, sir. We'll have, as Dr. Shubham said, question answers in the end, and be prepared, sir, to answer some of the questions. I would request Dr. Amitabh Gupta to please come here. Let's welcome Dr. Amitabh Gupta. Actually, my original plan was to ask Dr. Amitabh Gupta to chair this session of Dr. Anandh. Dr. Amitabh Gupta is a senior neurosurgeon, head of neurosurgery at PSRI hospital. Unfortunately, what transpired was that I had already given the moderators list to Sandeep, and he gave me the invite. So it was very difficult for me to, and he also told me it's difficult to change this thing. Sir, you please express your regrets, and sir, I express my regrets, my mistake totally. Please come here, sir. Please take the chair. Let's welcome Dr. Amitabh Gupta. Dr. Amitabh Gupta is going to give a short introduction of Dr. Anandh. He knows him personally, and he will steer the session for the question answer session.
Let me tell you, Dr. Anandh is quite a renowned neurosurgeon in India, and I had the privilege of working under him as a resident also. So this was in Cmes, and he was the associate professor there, and I learned so many things from him. And he's a gentleman of a kind, like very modest. He never boasts about his work. He went to Reliance in Kokilaben in Mumbai, and then after a successful stint shifted to Amrita. So whatever you are going to see, I would suggest that any difficult case, anywhere you are stuck up, you can always connect to him, and he's always available. He's always ready to give his opinion in a rightful way, as for the patient, not as a doctor. So kindly, I introduce Dr. Anandh. He's written many papers. He's on many like major NSI, what you call as Neurosurgical Society of India body, and Skull-Base Society of India. So he's a very coveted person. Even if I have a difficult case, I always try to contact him and refer it to him. Thanks. Sir, please.
Thank you so much, Amitabh. That was very humbling. Thank you so much, all of you, for being here. And a short introduction about myself. I had joined neurosurgery in 1993 after my MS from JIPMA and finished in 96, and continued to work in Cmes as faculty till 2008 when I met Dr. Amitabh. And then I went on to Kokilaben, as he said, and established the department there initially. After working there for 6 years, in the last 8 years I have been in Hyderabad in a hospital called Yashoda Hospital. And then when Amrita started here, because we wanted to, like Dr. Shaleen said, work for both academic and non-commercial outlook, we joined here in Amrita to do some good work. What I'm going to show you in the next 15-20 minutes is how neurosurgery has evolved over the period. And what I see here is most of the people here are senior to us, and you must have seen neurosurgery. Even in the days when I joined neurosurgery, people used to wonder, why are you so mad? Why are you joining neurosurgery? People just die. People don't make it. And I was discouraged joining neurosurgery. And as you know, all youngsters, the more you discourage them, the more they feel like wanting to do it. And I took it up as a challenge, and there were a lot of limitations at that point in time. There are limitations in technology, limitation in imaging. For years it was just angiogram and x-rays that used to guide the clinicians. They wanted to have an intact patient. Saving life was more important. There was no quality of life consideration because there were no techniques to do that. There was no technology to ensure that. Now we can do the aggressive surgeries, which was not justifiable before, because we can ensure safety. So that's where the whole thing has moved from being very cautious, primum non sera, towards taking as much effort as possible, utilizing all the technology, and then trying to make it as complete as possible for the patient. So not only they live longer, and they have a longer, good quality of life. So you see that there are advances in imaging, technological improvements, quality of life has come into focus. Malignant lesion, the prognosis has become predominantly excellent of it. The more you resect, the longer they survive, the better they do, provided you don't do any harm. And even in benign lesions, people used to even accept facial nerve paresis for resecting acoustic tumors because it's benign, you should not leave behind tumor. But now the controversy has moved more towards preserving the facial nerve, preserving quality of life, because we have other modes of treating the tumor, like radiosurgery, etc. I'm going to give you a large set of examples and how these kind of things work as quickly as possible. So this was what we were learnt in MBBS, the eloquent cortexes in the brain, as you can all recognize, the motor, the sensory, the Broca's area, the speech Wernicke's and the visual cortex. This was basically the eloquent cortex in the brain. Rest of the brain, if it got damaged, we used to just operate with impunity and take it away. But now, even without doing any dissection, with MRI you can see wonderful fiber tracts within the brain, which are all very eloquent. We can't say that the brain is not eloquent or vestigial organ, other than these 5-6 areas which we know. They are all interconnected and each one has a purpose, and we need to preserve them. So now we can do mapping. So electrophysiological monitoring has come in a big way to preserve safety for the patient. Just like the electrician keeps checking whether your electric circuit is intact, we can check every one of these fibers in detail with a test specific for them, either electrophysiological or physiological testing. I'll give you some examples. This was a deep-seated tumor on the left side. Normally this was considered as inoperable because you have to go through the left temporal region, which is speech area. So patient was considered as non-operable. But when we did a functional MRI, lo and behold, the speech area was all distributed on the right side. So we could confidently operate from the left. This intraop MRI of the patient showing left-sided tumor removal going through the left temporoparietal region without any speech deficit. Same thing on the left side, motor cortex, large lesion left behind. This is the cavity of the lesion posteriorly, because it was thought that this lesion could not be resected anteriorly, and this was reported as low grade. We know these are notorious tumors, low grade gliomas. They can be high grade in some areas. So these areas, when we did a perfusion scan, lit up. So we knew it was malignant, but we needed histology, we needed more decompression. So that's what we did. What did we do? We did a fiber tracking imaging to find out where the fibers are displaced. They were all displaced anteriorly. So we had a safe corridor to go from posterior and decompress more. And that's what we did with intraop MRI guidance again. And patient could be resected much more, a third grade established, and undergo radiation and chemotherapy post-op rather than wait and watch. This is another case where you can see it is right in the speech area, and we did functional imaging, showed the speech is not in the surface, it has been displaced deep. So we could go ahead and resect with intraop MRI again and with monitoring, and stop short at exactly where the speech area was present and resect all the tumor that's superficial to it without causing a speech deficit to the patient. So this kind of mapping and doing surgery has been there for decades, but we did not have any imaging guidance. So nowadays we have imaging guidance not only preoperatively but intraoperatively too. Again, a similar example right in the motor cortex, which could be resected safely. Though we have to leave behind vestigial tumor, we are sure that patient does not have a deficit. As you can see here, intraoperative mapping, posteriorly tumor left behind with intraoperative imaging, and that area stimulated, producing motor effects, and so you stop resection based upon electrophysiology. Large irregular tumors also can be resected with intraoperative image guidance, as you can see here. And we can even use fluorescence, as you can see in these images. I'll quickly forward this video. This is called ALA fluorescence, that is pink color, and this is the yellow fluorescence, which we normally use because it's much cheaper and easier, and it's very useful in cases where there is a fluorescence. The tumor fluoresces yellow and the rest of the brain surrounding looks normal, and it's very easy to differentiate between them. It's very useful in cases where there is enhancement of the tumor and break in blood-brain barrier. Very complicated tumors in insular areas, we can still use these principles of stimulation and also neuronavigation. As you can see here, right under the microscope, you can see area within the tumor which shows up under the microscope, delineated as separate areas. As you can see here, when you pull up the images, you can see the outline of the tumor, very beautifully seen. And as you change the focus, the area of tumor that you have delineated changes, giving you a clear-cut indication as to which area within which you have to stay and which area is not safe. Now ultrasound has come into the picture. Navigation along with ultrasound makes life much easier. While you are operating, you need not wait at the end of the surgery to do the MRI. You can real-time do ultrasound, fuse it with the MRI images. So this kind of technology is now available with us, and it can be fused with the fiber tracking, which makes it very, very good for the patient to have a very safe outcome at the end of surgery. So maximal resection, we use microscope, MRI, ultrasound, navigation and fluorescence. And for safety, we use intraocular electrophysiological monitoring, diffusion function imaging, sensor imaging, functional MRI, navigation, etc. Now, a few words about other branches of neurosurgery other than just tumor. You would have seen neurosurgery is actually a mile wide. You have degenerative disorders, vascular disorders, infective disorders, traumatic disorders. All of them may require surgery at some point in time. Even infective disorders, degenerative disorders like Parkinson's disease. We know neuromodulation. I'll just show you a quick video clip here of Parkinson's disease patient preoperatively having very severe tremor. Of course, these patients have to be selected very carefully. We have a wonderful neurologist with us, Dr. Sanjay Pandey, who was at GB Pant, head of neurology there. He is a movement disorder specialist. They assess the patient, and once they feel that this patient is suitable for surgery, then this bad bradykinetic, akinetic, tremor predominant patient who can't even get up, you can see that patient is not even able to get up when we ask them to. Is immediately after the surgery, post DBS, you can deep brain stimulation where we put in an implant and cause the stimulation of the subthalamic nucleus. The patient works as though he had taken Syndopa and has maximum effect of the drug. So this can be done in carefully selected patients, and this is also not only in Parkinson's disease. This is the case of tardive dyskinesia, wherein a patient who had neuroacanthosis, I'm sorry the video is not playing, maybe the next video, I'll just see. I'll skip this, maybe I'll show you, yeah, this is after the surgery. He could not stand, he could not sit, but he, after the surgery of doing a DBS, he is able to walk independently. Otherwise, they could not make him sit on a chair or even lie on a cot because he used to fall off. He was so dyskinetic. This is a patient of orolingual dystonia who had come from abroad. If he wanted to speak, his tongue used to protrude out and he could not speak. He was actually a politician and he thought the opposition has poisoned him that he cannot speak. And he came over and got a DBS done, and this is after the DBS for orolingual dystonia. We can see that he is able to use his faculty of speech comfortably without the tongue protruding out all the time, and he is able to have better outcome.
Sir, Wambari Congress.
We don't know what other parties there. He came from Uganda, so I do not know what is the political scene there. So electrophysiology is very important even in neuromodulation. Now coming to epilepsy. Epilepsy is, we all know, is just a medically treatable disorder mostly. But there are lots of cases of intractable epilepsy which can be cured by surgery to a large extent, and that is a huge population. There are MR negative epilepsies. Even if you work up with MRI, you may not find out where it is. Technology has advanced so much that we can put in electrodes in the brain. As you can see here, more than 10 electrodes are put in the brain, recorded from deep inside, so that we know where the EEG focus network comes out, or normal network comes out, and we can attack that network specifically by doing either resection, or if it is not resectable, as in this case what we have done RF ablation, because this area was not resectable and this entire area was ablated with RF. We made almost 80 lesions, RF ablation, and the patient is seizure-free now even at the end of 1 year. Electrophysiological guidance in routine surgeries like benign tumors, like in acoustic tumors, I said, now we can monitor the nerve accurately. Previously we were very happy to preserve it anatomically, but now it is very challenging. Patient does not want to wake up with a 7th nerve deficit, because lifelong it's a reminder for the patient that they had a tumor, they got operated. The tumor is treated, but the face is disfigured. So we cannot afford to give the disfigurement to the patient. To save the nerve, we have to monitor. Even if you have to leave behind tumor, doesn't matter. Large tumors like this, patient facial nerve preserved, because when you are dissecting the residual tumor, which may be very thin, which may be very small, if the nerve is getting disturbed, we stop because we monitor and do the surgery. Then what do you do to the residual tumor? It's benign, it won't grow back again. Even if it grows, we can shoot it with radiation, radiosurgery. So that becomes very useful. That is the next tool that I will talk about. Before that, I'll tell you about endoscopic surgery through the nose that has revolutionized pituitary tumors, even functioning tumors like this large growth hormone secreting adenoma. We can resect the tumor completely, preserve the normal gland. As you can see here, this is the large tumor, normal gland on the right, that is preserved. The rest of the tumor is removed. We have intraoperative evidence with MRI, and post-operatively the hormonal profile also gets well preserved if you don't radiate. So pituitaries you don't have to radiate, and you can resect them completely with endoscopic and intraoperative image guidance. Spine surgery has also got revolutionized with imaging and guidance. As you can see here, complex 4-level, 5-level fusions can be done with percutaneous screws placed through trajectories planned before the surgery using navigation. So minimal invasive spine, again at Amrita, the ortho and the neurospine work together, like the neurologist and neurosurgeon work together for movement disorders or epilepsy. So it becomes a good team. You don't have to worry whom to refer the patient to. If you just send to us, the responsible specialist will take care. So here you can see both the neurospine surgeon, orthospine surgeon together doing an intervention procedure in the hybrid cath lab, where we use the flat panel in C-arm to give us direction. We also know about vascular disorders like aneurysm. We have an interventional neuroradiologist who works along with our neurovascular surgeon, and both of them counsel the patient together whether the patient is suitable for coiling or clipping. Then the patient's suitability and affordability, we choose which one to go. It's not like patient has come to me, I know to do clipping, so I'll do only clipping. So what is suitable to the patient, right to the patient, we do. We do have stereotactic radiosurgery facility too, which increases the treatment possibilities for benign lesions, metastasis, AVM. You might have heard of gamma knife, X knife, cyber knife. This is a variety of radiosurgery. It's called X knife maybe if you want to call it. And this is the same radiosurgery technology that we have as much as in gamma knife, X knife, cyber knife or Zapex. That are names of various machines, but the delivery and the principle of delivery is all the same. So maximum safety, taking care of functionality. Measured aggression in malignant lesion, improving extent of resection, guarded conservative resections in benign tumors, limiting or avoiding morbidity, using hybrid treatment, use of technology with a purpose, not because I have a machine I'll use it. Like they say, a person with a hammer finds everything like a nail. But it's not the case here. We want to use technology for the best benefit of the patient, like the institute has been formed with compassionate care. And good understanding of the tool at hand and anatomy and physiology is important, and effective use of the same for patient comfort. It does make life difficult for the surgeon, but if we don't strive harder, how can we make others get better? So with that, I will thank you for your attention.
Very good. Friends, before we start the question and answer session, a small presentation from Dr. Shetty. Am I audible?
Yes, sir.
Okay. I invite Dr. Shetty sir to please come here. I did not want to confuse the issue and mix up this thing with the felicitation. I would request Dr. Shetty sir to introduce himself and also to introduce the wonderful work that he is doing, his written book, and that he would be presenting to Physician Forum of India. Sir, kindly introduce the book, the context, and about yourself.
I am practicing in South Delhi, Jalpura Extension, for the last 40 years. And for the last 40 years, my second passion is painting. So I have done my basic from NGMA, National Gallery Modern Art, and this was a passion within a passion. It was a dream come true. And recently I had 3 solo shows in the major galleries of Delhi, like Triveni Kala, like IFAX, and like IIC. And after that, my works had gone to Japan recently, Tokyo, for an international show. So that was in the painting. And for writing, I have been writing for the last continuous 20 years for DMA. There's a essay competition there called Dr. K.K. Sharma Essay Award Function. And I had continuously got the first prize almost.
So thank you for being with us, and I would want to open the forum with very basic questions which are very important for any physician referring in patient. So first of all, we want to know what is the cost of liver transplant as a package at Amrita, and how is it placed as compared to maybe the other competitors in the field.
So that transplant package at Amrita is 70 lakhs. That includes the donor workup also, because most of the other hospitals put the donor workup separately, which itself costs around 1 lakh. So actually you compare with other hospitals, it would be 60 lakhs, but I am putting the total cost that comes to the patient is around 17 lakhs. This is more or less the same which is the CGHS rate. CGHS rate is around 15.5. So it's not very different from the CGHS rate. And this other hospitals, say Delhi NCR, charge variably from around 19 to 25 lakhs. And now outside Delhi NCR is even higher, at least 25. So we are very reasonably placed, and just because that our CEO, Ram Ganpati, had said that we are a non-profit organization. So that's why we have been able to keep the cost low. And for patients who are from distinctly or maybe backward classes, we have special considerations for these patients where we can even go lower.
Sure, the very interesting thing, one which I've seen is with my patients, there is a doctor who got liver transplant for his real brother, and went very well in South India. So it was around 5 years ago, and I came across a concept that DDLT is more common in South India. So just a minute. So Amrita coming from South India, are you doing or can we expect DDLT to be done at Amrita Faridabad because originally it comes from the south? Or there is maybe a technical thing why DDLT cannot be done in North India?
So to answer your question, you are absolutely right that the frequency of deceased donor organ transplant is higher in the southern states, especially cities like Agarwal, Chennai, now even Pune. Kerala is an exception. So the numbers of deceased donors were higher up to a few years back, and they are still a bit higher, but the gap is reducing because the activity of deceased donor liver transplant is picking up in North India. And answering your second question, whether it can be done at Amrita, it is not can. We have already done within the last 4 months 3 deceased donor liver transplants. So we are approaching a frequency of 1 per month at least in-house donation. So deceased donor transplants are being done at Amrita, and our frequency is only going to up. The simplest reason is people who are donating, usually they are skeptical when they make donations in a corporate hospital because they think that the doctor is making money out of it. But when they come to Amrita, they are assured that this is a hospital, it's Sama's hospital, it's not about profit. All doctors here are on their salaries, they are not going to make any money out of this donation. And the body of their living, the dear one, near and dear one that they are donating, the organs would be going to the really needy people. And people have actually donated the whole bodies to Amrita without asking any questions. So it's not a question of can, it's being done at Amrita.
So, sir, this is very important for all of us to understand that I don't think DDLT, disease donor liver transplant, is done anywhere in North India. If it is being done at Amrita, it is something which all of us should know. And if 3 or 3 have been done, I think you should publicize it more, because I was not aware. As a gastroenterologist, in the last 7 years, I have got at least 50 of my patients transplanted, but all of them were NDLT. The only doctor I know got a DDLT. So the last thing is, I just want to know your complication rates. Then I open this for the thing of what I know. Like I might be less exposed of basic things. Hepatic artery thrombosis, early, second, post LT BBS, benign biliary strictures, and do you have like an expert gastroenterologist to do an ERCP or a BBS post liver transplant?
So, by God's grace, the hepatic artery thrombosis rates are, I would say, not only less than 1%, I would say even less than 0.5%, but that's by God's grace. they are very good. As far as biliary stricture is concerned, the percentage is around 8 to 9% for only for living donors. In deceased donors, I have not. We have been doing deceased donors also, as I said, at least once a month. So the deceased, and when I am in the previous hospitals also, there were some donations. So that in deceased DDLT, the biliary stricture rates are again very low, the tune of 2 to 3%. In living donor, just because of the complexity of the surgery and the small size of the bile ducts, they are due to the tune of around between 8 to 10%. And yes, majority of them can be managed by arthroscopy, like people who are very good at acting these stents and placing stents. And usually the patients require 2 to 3 stents. There have been few cases where the stents could not handle the stricture and I had to go back and do a repeat surgery in the form of a hepatic angiogram.
I should complete that to Dr. Suraj Bhagat.
Yes.
So I think there's this guy, Dr. Suraj Bhagat, he's my senior, and I think he's an expert at ERCP in post liver transplant BBS, and I think he's done really good work. Yeah, he's done really good work. I've done 2, sir, at PSI. After that, I was not at liver transplant center, but it's a tough job.
Yeah.
So post liver transplant, benign biliary strictures, ERCP is a tough job. Suraj Bhagat is a very dear friend, and he's an amazing guy.
Yes.
So I think he's one of the persons we can reference. So he's with Sir at Amrita. He was earlier. He was my senior at Cmes, and he was at Medanta, and then he's with Sir. So that's my request to him, sir.
Sure.
And I open the stage for the questions. Thank you.
Thank you for a wonderful session, Dr. Shaleen. You mentioned in your talk that hepatitis A is one of the commoner causes of acute liver failure. What we were told when we were doing our PG in 86, 87, 88 was that it was hepatitis B and hepatitis C, which were common causes of this and responsible for liver transplant. Sir, has the scenario changed with hepatitis A, or is something to do with immunity or something else?
No, sir, it's totally changed because hepatitis B and C, as I talked about in my presentation, the prevalence has come down because of universal vaccinations for hepatitis B, and for C, it's like it used to be transmitted through unscreened blood. So now majority of the blood that's being transfused is screened for hepatitis C. And secondly, there are very good antiviral medications available for hepatitis C. So if somebody is detected with a higher viral load, they can be totally like more than 99% cure rates at 12 to 24 weeks of antiviral. So the prevalence has gone down drastically. On the other hand, the hygiene levels as far as food and waterborne diseases are concerned still remains high. And as we all know, hepatitis A is transmitted, is a food and waterborne disease. And there are like kind of pandemics as well as seasonal variations in the incidence of hepatitis A. And since it's so common, although the percentage of hepatitis A patients going into acute liver failure is minuscule, but since the denominator is so large, so we are getting, and all hospitals, whether in government or private sector, they are getting large number of young patients with acute liver failure secondary to hepatitis A. It's not, percentage wise, it's like the incidence would be 0.1 or 0.2%, but since the incidence is so high, majority of them are not even detected. So the number, in actual numbers, the patients that are coming to hospitals with acute liver failure secondary to hepatitis A has gone up drastically.
Sir, another common cause of acute liver failure is drug-induced liver disease, or DILI. And India happens to be a very high endemic country for tuberculosis. And there is a very high incidence of anti-tubercular drug abuse because they are not properly supervised. What is your experience of ATT-induced liver injuries or drug-induced liver injuries? Part 1. And number 2, there used to be a drug called Nimesulide, which we were using left, right and center for treatment of fever. And it was banned by Government of India. What is your view on that drug? These two questions.
So, to answer your first part of the question is that DLI, especially really caused by anti-tubercular medications. So, as you rightly said, DD secondary to ATT is extremely common. It is the commonest cause. Normally, we blame Ayurvedic medicines for that, but ATT stands as the first cause of DD in our country, followed by complementary and alternative medicine practices. So, I'm not supporting any one therapy or one pathy against the other, but ATT stands as the number one cause, and simply because of, as you rightly said, indiscriminate prescription of ATT, and even after prescription, the liver function not being monitored by the treating physician. Because if they are detected in time, most of these patients won't land up in the ICU, and I have transplanted patients for subacute liver failure. The problem with drug-induced liver failure is that it is usually present in a subacute form, and spontaneous recovery is not that common as in hepatitis A. So many of these patients do land up with liver transplant, and I have myself transplanted, although the numbers are in single digits, but I have transplanted several patients because of liver failure secondary.
So there was this case series by Dr. S K Acharya, a teacher from Cmes. So ATT-induced acute liver failure definitely stands out. And if we can just do day 3, day 7, day 14, day 28, because ATT-induced hepatitis is a hypersensitive reaction. It's an idiosyncratic reaction. It happens within the first 2 weeks, most commonly, maximum within the first 4 weeks. If you catch within the first 4 weeks and you even introduce rifampicin and isoniazid again without pyrazinamide, these patients do not enter into acute liver failure. So if ATT is started without monitoring LFT, then there is a big problem.
You are absolutely right.
Dr. Sarath Gopalan.
Thank you, Dr. Shaleen. You have transplanted 4 of my patients, quite well. And I am speaking as a pediatric gastroenterologist, giving a different perspective. There are 2 broad categories: hepatitis A-related liver failure and extrahepatic biliary atresia, which the audience here may not be really interested in. But hepatitis A, you've transplanted 3 of my patients in various places we worked over so many years. The point is that it's a strong case for a hepatitis A vaccination program in India at the government level, which is still not happening.
So the debate is still going on.
Yes, and it should happen because the reason is, as far as the family is concerned, it's not statistics. It's either 0% or 100%. It's as simple as that. So we just need to work on that, and it's a very important issue.
Sir, Dr. R. K. Saxena, sir, an alumnus of All India Institute of Medical Sciences, a neurosurgeon, an excellent neurosurgeon practicing in West India.
Sir.
No questions, just a comment. Most of you know of my cadaveric transplant I did on the New Year's Eve. I have to inform you or tell you that the cadaver was at the Amrita hospital. And on that New Year Eve, that cadaveric kidney that I got was from Amrita hospital. So I have a first-hand experience of going there, visiting that hospital, walking those corridors, and the wonderful hospitality I had there. And the OTs were fantastic, state of the art, with lovely equipment, no dearth of material, drugs, even manpower late at night. So I was thoroughly impressed by the hospital. I wish them all the way.
Thank you, sir.
Thank you for your comment, sir. From here, Dr. Rani Chakravarti, ma'am.
Sir, you were saying that now in alcoholic persons also you are doing transplants. I came across a person who was given psychiatric clearance that this person will not go back to. So is it mandatorily required for all the patients?
Ma'am, psychiatric clearance is part of that protocol that has been created by NATO, which is the government organization. And because it's followed in the West, yes, psychiatric clearance is required.
It is required. And secondly, sir, you said in cases of cardiac death, if the relatives are willing, you gradually take off the supports. Is that legally correct?
Yes, totally correct.
Okay.
There's a lot of controversy about withdrawal of supports, but I've talked to, and Dr. Anandh can let us know better, but withdrawal of support is not illegal. It is totally legal, and many intensivists, senior intensivists are regularly practicing withdrawal of care, not for point of organ donation itself, but for cost cutting, for the benefit of the family. After detailed discussion with the family, it is purely legal withdrawal of support.
So can we put it on record in the history, or
yes, you
just...
can put it on record, and
okay.
nobody will hold you responsible in a court of law.
Okay, thank you.
Anything? Dr. Chakravarti, sir? Ashok Chakravarti, sir?
Good evening, sir. Good evening, Dr. Shaleen, for wonderful presentation on the liver transplant. You very rightly said that in fact hepatitis A remains one of the most important causes, and it's absolutely preventable disease because of vaccination we have got. But despite that, underprivileged children where the Government of India doesn't provide the UPI infective hepatitis vaccine. We do see cases of adolescent having infective hepatitis. I would suggest only one thing, that in all cases of infective hepatitis whosoever come to, don't only restrict to LFT. Please go for INR also. Because that's a very strong indicator whether the child is going to potential liver failure or not.
So the decision for transplant basically is based on two parameters.
Yeah, exactly.
One is the INR and other is the development of hepatitis.
Yes, exactly. The symptomatic. Thank you so much, sir, for wonderful talk.
Thank you.
Thank you for your input, Dr. Chakravarti sir. Dr. M.P.S. Gandhi, our guru, ex-CEO of Charakpalika Hospital.
Sir, what was the minimum and the maximum age of the patients where liver transplant has been performed at your place, and what was their survival rate?
Sir, minimum is 1 month. An infant, 1 month old was a metabolic disorder, propionic acidemia, if I remember correctly, that was the minimum age. And the maximum is 76 years for liver cirrhosis due to hepatitis C with hepatocellular carcinoma. And I still remember it's more than 10 years. There was a Pakistani patient who was a resident of UK. He flew down from UK to get a liver transplant from us.
Dr. Tulsi sir, as I said, Dr. Shaleen sir, get ready for your MCH Viva sir.
No, MCH Viva, just very simple questions. So that was a great talk, Dr. Shaleen Agarwal. So as you said, as Dr. Shubham as well said, the etiology of cirrhosis is forever shifting. See, it was alcohol, it is, over time, alcohol-related cirrhosis versus NAFL or MAFL. So, in US, probably the biggest concern is the alcohol abuse, chronic alcohol abuse. What about in India? With so much of diabetes, we have obesity also. So would you say probably the NAFL or the MAFL or the MESL probably would be the forerunner here?
Sir, so if we talk about the United States, you rightly said that alcohol abuse used to be the commonest.
Chronic, yeah.
Now, NAFL or MAFL as we call it, they are running neck to neck. And it is expected that towards the end of the decade, MAFL would exceed alcohol as the primary cause of chronic liver disease in North America.
Absolutely.
As far as we are talking, when we talk about our own country, so our data is not so robust, but whatever data is, Indian data is available, right now, alcohol is above MAFL in our country, but as you rightly said that with India being the epicenter of diabetes epidemic, MAFL is going to surpass alcohol in the coming years.
So less and less viral hepatitis, hepatitis B, C, ever since the advent of direct-acting antivirals drugs which were introduced in 2014, we are seeing less and less about that.
You are right, sir.
So let me talk to you about robotic liver transplants. See, there have been very few cases. It's very challenging. It's a steep learning curve that you have on robotic liver transplant. Are you doing
whatever is minimally invasive? Initially we started with laparoscopic. It started from Korea and then we picked up. So in my initial training and experience, I've done around 150 laparoscopic donors, and then I shifted to robotic, and I found that the robotic platform was much more accurate, much more comfortable, and I've done more than 250 robotic donors till date. And the largest experience is from Professor Dieter, who is a German surgeon based in Saudi Arabia. Digits, but I think, I don't know, it is a test of time. I have not convinced yet, and I have not done any recipients robotically, because for a recipient, unlike a donor, it's not the incision which matters. It is the quality of the graft and the functioning of the graft which matters. Vis-a-vis the donors, where the scar, the incision of the surgery is a great concern. So robotic recipients are in single digits.
anastomosis of the hepatic artery and the portal vein, which is really challenging? What do you say, sir?
Yeah, it is
with robotic.
Yeah, with robotics, the advantage of robotic is the stability and magnification. So in a way, sometimes doing an artery is easier robotically, but when you consider the entire surgery, the length of surgery increases markedly with on the robotic platform, and the warm ischemia times, that is the graft without liver kidney, sir?
No, sir. We're talking about one adult and a pediatric patients. See, giving a liver, a right lobe to the adult liver and left lobe to a pediatric patient.
So that is possible only in the cases of deceased donor liver transplant, where you have full liver, and then that is called the split liver transplant, where you give the 2/3 of the right liver to the adult.